Study section 10. The anatomy and physiology of the fetus and foetal. Introduction. In the previous study section, you have learnt about the placenta, which links the fetus closely with the mother's circulation to perform many functions. The survival of the fetus depends on the integrity of the placenta. In this study section, you will learn about the anatomy and physiology of the fetus and foetal. These organs are of vital importance to the midwife because of their effect on the newborn baby. Learning outcomes. At the end of this study section, you should be able to discuss the fetal circulation, explain how the baby adapts to intrauterine life, highlight parts of the fetal skull, the bones, structures, fontanelles, landmarks, diameters, and presentation. The fetal circulation. The key to understanding the fetal circulation is the fact that oxygen is derived from the placenta. In addition, the placenta is the source of nutrition and the site of elimination of waste. Temporary structures, in addition to the placenta and the umbilical cord, enable fetal circulation to take place. These temporary structures are: A. The umbilical cord. Take 2. The umbilical vein. It leads from the umbilical cord to the underside of the liver and carries blood rich in oxygen and nutrients. It has a branch which joins the partial vein and supplies the liver. B. The ductus venous connects the umbilical vein to the inferior vena cava. At this point, the blood mixes with deoxygenated blood returning from the lower parts of the body. C. The foramen ovale is a temporary opening between the arteriole which allows the majority of blood entering from the inferior vena cava to pass across into the left atrium. D. The ductus arteriosus. From an artery to an artery leads from the bifurcation of the pulmonary artery to the descending aorta, entering it just beyond the point where the subclavian and carotid arteries live. The hypogastric arteries branch off from the internal iliac arteries and become the umbilical arteries when they enter the umbilical cord. They return blood to the placenta. The blood takes about half a minute to circulate and takes the following courses. Diagram of the fetal circulation. From the placenta, blood passes along the umbilical vein through the abdominal wall to on the surface of the liver. This is the only vessel in the fetus which carries unmixed blood. The ductus venous carries blood to the inferior vena cava where it mixes with blood from the lower body. From here, the blood passes into the right atrium and most of it is directed across the forearm ovale into the left atrium. Following its normal route, it enters the left vehicle and passes into the aorta. The heart and brain, the arms each receive a supply of well-oxygenated blood. Blood collected from the upper parts of the body returns to the right atrium in the superior vena cava, passes into the right ventricle. There is a mixing of 25% of the blood, allowing a little oxygen and food to be taken by the lungs through the pulmonary artery. The remainder passes through the ductus arteriosus to the aorta. Blood continues along the aorta and supply the remaining body organs and legs. The internal iliac arteries lead into the hypogastric arteries, which return blood to the placenta via the umbilical arteries. The remaining blood supplies the lower limbs and returns to the inferior vena cava. Adaptation of extrauterine life. A. Closure of the flap over the forearm ovale. B. The ductus arteriosus constricts and close. C. The umbilical vein becomes the ligamentum teres. D. The foramen ovale becomes the falx ovalis. E. The baby obtains nutrition through breastfeeding. F. The baby eliminates waste through the kidney and gastrointestinal tract. The foramen ovalis becomes the fossa ovalis, and the hypogastric arteries are known as the obliterated hypogastric arteries, except for the first few centimeters, which remains open, and the superior vesical arteries. After birth, the baby has to obtain nutrition through the establishment of breastfeeding or a breastfeeding substitute, and to eliminate waste via the kidneys and gastrointestinal system. Other complex changes take place also. A diagram of the frontal view of the fetal skull and the side view of the fetal skull. The fetal skull contains the brain. It is large in relation to the fetal body and in comparison with the true pelvis. Therefore, some adaptation between skull and pelvis must take place during labor. The head is the most difficult part to deliver, whenever it comes first or last. An understanding of the landmarks and measurements of the fetal skull enables the midwife to recognize normal presentation and position and to facilitate delivery. Where malpresentation or disproportion exists, she will be capable to identify it and alert the medical staff. Ossification. The bones of the frontal head originate in two different ways. The face is laid down in cartilage and is almost completely ossified at birth, the bones being fused together and firm. The bones of the vault are laid down in membrane and are much flatter and more pliable. They ossify from the center outwards, and this process is incomplete at birth, leaving small gaps which forms the sonchal and fontanelles. Bones of the vault. There are 5 main bones in the vault of the fetal skull, namely the occipital bone. This lies at the back of the head and forms the region of the occiput. Part of it contributes to the base of the skull, as it contains the foramen magnum. At the center of it is the occipital protuberance. The 2 parietal bones. This lies on either side of the skull. The ossification center of each is called the parietal eminence. The 2 frontal bones form the forehead or synapse. At the center of each is a frontal boss or frontal eminence. The frontal bones fuse into a single bone by 8 years of age. A diagram. The 2 parietal bones. This lies on either side of the skull. The ossification center of each is called the parietal eminence. The upper part of the temporal bone is also flat and forms a small part of the vault. Sonchos. Sonchos are cranial joints and are formed where 2 bones are joined. Where 2 or more sonchos meet, fontanelle is formed. The sonchos and fontanelle's osteurical significance are described below. The lambdoidal suture. This separates the accipital bones from the 2 parietal bones. The coronal suture. This separates the frontal bones from the parietal bones, passing from one temple to the other. The sagittal suture. This lies between the 2 parietal bones. The frontal suture. This runs between the 2 halves of the frontal bone. The frontal suture becomes obliterated in time, while the other suture eventually become fixed joints. Ossification of the skull is not complete until early adulthood. The posterior fontanelle or lambda. This is situated at the junction of the lambdocidal and sagittal structures. It is small, triangular in shape. It normally closes by 6 weeks of age. The anterior fontanelle or bregma. This is found at the junction of the sagittal, coronal, and frontal suture. It is broad, kite-shaped. It measures 3 to 4 cm long and 1.5 to 2 cm wide, and normally closes by the time the child is 16 months old. Pulsation of cerebral vessel. can be felt through it. The sutures and fontanelle, because they consist of membranous spaces, allows for a degree of overlapping of the skull bones during labor and delivery. Regions and landmarks of the fetal skull. The skulls are divided into the vault, the base, and the face. The vault is the large dome-shaped part above an imaginary line down between the arbitrary ridges and the nape of the neck. The base is comprised of bones which are firmly united to protect the vital centers in the medulla. The face is composed of 14 small bones which are also firmly united and non-compressible. The regions of the skull. The regions of the skull are described as follows. A. The occiput lies between the foramen magnum and the posterior fontanelle. The part below the occipital protuberance is known as the suboccipital region. The protuberance itself can be seen and felt as a prominent point of the posterior aspect of the skull. B. The sinciput or brow, extended from the anterior fontanelle and the coronal suture toward the orbital ridges. C. The face is small in the newborn baby. It extends from the orbital ridges and it roots off the nose to the junction of the chin and the neck. The point between the eyebrow is known as the glabella. The chin is termed the mentum. D. Diameter of the fetal skull. The measurements of the skull are important because the midwife needs a practical understanding between the fetal head and the mother's pelvis. There are two transverse diameters, namely biparietal diameter 7.5 cm between the two parietal eminences, bitemporal diameter 6.2 cm between the furthest points of the coronal suture at the temple. The remaining diameter describes the anterior, posterior, or longitudinal. Suboccipital bregmatic 7.5 cm from below the occipital protuberance to the center of the anterior fontanelle or bregum. F. Suboccipital frontal 10 cm from below the occipital protuberance to the center of the frontal suture. Occipital frontal 11.5 cm from the occipital protuberance to the glabellus mentovertical 11.5 cm from the point of the chin to the higher point on the vertex, slightly nearer to the posterior than total arterial fontanelle. Submental vertical 11.5 cm from the point where the chin joins the neck to the higher point on the vertex. Attitude of the fetal head. This term is used to describe the degree of flexion or extension of the head of the neck. The attitude influences the outcome of labor. Attitude of the fetal head presenting diameters. The diameters of the head, which are called the presenting diameters, are those which are at right angles to the curve of Carus. There are always two on anterior-posterior or longitudinal diameter and a transverse diameter. The diameters presenting in the individual cephalic or head presentation are as follows. A. Vertex presentation. When the L is well flexed, the suboccipital pragmatic diameter and the pregretta diameter presents. As these two diameters are the same length, 7.5 cm, the presenting area is circular, with the most favorable shape for dialing the cervix. The diameter which distends the vaginal orifice is the suboccipital frontal diameter, 10 cm. When the head is not fixed but erect, the presenting diameter at the occipital frontal, 11.5 cm, and the biparietal, 7.5 cm. This situation often arises when the occipital is in a posterior position. If it remains so, the diameter distending the vaginal orifice will be in the occipital frontal, 11.5 cm. B. Brow presentation. This is when the head is partially extended, the mental vertical diameter, 11.5 cm, and the bitemporal diameter, 6.2 cm present. If this presentation persists, vaginal delivery is extremely unlikely. Face presentation. When the head is completely extended, the presenting of diameters at the submental pragmatic, 7.5 cm, and the bitemporal, 6.2 cm. The submental vertical diameter, 11.5 cm, would distend the vaginal orifice. Attitude of the fetal head. Diameters of the fetal trunk. There are two fetal trunks, namely A. Bisacromial diameter, 12 cm. This is the distance between the acromion processes on the two shoulder blades and its dimension that needs to pass through the pelvis for the shoulder to be born. The articulation of the clavicles on the sternum allows for movement of the shoulders, which may reduce the diameter slightly. B. Bichogastric diameter, 10 cm. This is measured between the greater trunchata of the femurs and is the presenting diameter in breech presentation. Attitude of the fetal head. Molding. This is the term applied to the change in shape of the fetal head that takes place during its passage through the birth canal. Alteration in shape is possible because the skull bones are able to override at the junctions. This overriding allows a considerable reduction in the size of the presenting diameters. Molding is a protective mechanism and prevents the fetal brain from being compressed as long as it is not excessive, too rapid, and in an unfavorable direction. Study section summary. In this study section, you have learned that 1. Oxygen is derived from the placenta. In addition, the placenta is a source of nutrition and site of waste elimination. Temporary structures in addition to the placenta enable fetal circulation to occur. 2. At birth, cessation of placenta circulation occurs. There is establishment of pulmonary circulation nutrition through breastfeeding, while elimination is through the kidneys and gastrointestinal system. 3. The fetal skull contains the brain. Understanding the landmarks and measurements of the brain enables the midwife to recognize normal presentations and positions to facilitate delivery. End of study section 10. Thanks for listening.